Good morning, Mom. Uh, Today I will report about uh, pyloric stenosis. What is pyloric stenosis? Pyloric stenosis, also known as infantile hypertrophic pyloric stenosis or IHPS, is the most common cause of intestinal obstruction in infancy. It is characterized by hypertrophy of the circular muscle fibers of the pylorus with a severe narrowing of the lumen. The pylorus is thickened to as much as twice its size, is elongated, and has a consistency resembling cartilage as a result of this obstruction at the distal end of the stomach. The stomach becomes dilated. So, ito yung nag-cause ng bara sa isang infant, and after magka-obstruction, ma-dehydrate yung infant. So, next is static and incidences. The incidence of infantile hypertrophic pyloric stenosis is 2 to 4 per 1,000 live births. Death from infantile hypertrophic pyloric stenosis is rare and unexpected. The reported mortality rate is very low and usually results from the delays in diagnosis with the eventual dehydration and shock. Infantile hypertrophic pyloric stenosis is more common in whites than Hispanics, Black, or Asians. The incidence is 2.4 per 1,000 live births in whites, 1.8 in Hispanics, 0.7 in Blacks, and 0.6 in Asians. Infantile hypertrophic pyloric stenosis has a male-to-female predominance of 4 to 5, with 30% of patients with infantile hypertrophic pyloric stenosis being firstborn males. The usual age of presentation is approximately 2 to 6 weeks of life. Approximately 95% of infantile hypertrophic pyloric stenosis cases are diagnosed in those aged 3 to 12 weeks. So, suddenly nag-appear ang pyloric stenosis within 3 to 5 weeks after birth, at saka rare ang pyloric stenosis sa babies na 3 months older. Next is causes. The causes of infantile hypertrophic pyloric stenosis are multifactorial. First is exposure to antibiotics. A cohort study found that treatment of young infants with macrolide antibiotics was strongly associated with infantile hypertrophic pyloric stenosis or IHPS. So dahil sa exposure ng antibiotics, dito nagde-develop ang pyloric stenosis. So next is genetic factors. A nationwide study of nearly 2 million Danish children born between 1977 and 2008 shows strong evidence of familial aggregation and heritability of pyloric stenosis. So, possible din na namamana ito from the circle of your family. So, next is nitric oxide impairment of this neuronal nitric oxide synthase or NNOS synthesis has been implicated in infantile hypertrophic pyloric stenosis in addition to achalasia, diabetic gastroparesis, and Hirschsprung disease. So, possible din dahil sa low serum ng lipids. So, for clinical manifestations, pyloric stenosis is rarely symptomatic during the first days of life. It has occasionally been recognized shortly after birth, but the average affected infant does not show symptoms until about the 3rd week of life. So, saka lang siya nagpapakita ng symptoms pagdating ng 3 weeks old ng isang infant. So, next is vomiting. Classically, the infant with pyloric stenosis has non-bilious vomiting or regurgitation, which may become projectile in as many as 70% of cases, after which the infant is still hungry. So, kahit na ano pang inumin or kainin ng infant, isusuka niya pa rin ito. So, next is jaundice. The infant may develop jaundice which is corrected upon correction of the disease. So, nagiging yellow na ang bata after magkaroon ng signs and symptoms. Next is dehydration and malnutrition. As the obstruction becomes more severe, the infant begins to show signs of dehydration and malnutrition such as poor weight gain, weight loss, marasmus, decreased urinary output, lethargy, and shock. So, nagkakaroon na ng dehydration dahil meron ng obstruction sa isang infant. So, next is palpable pylorus in as many as 60 to 80% of the infants with infantile hypertrophic pyloric stenosis or IHPS affirm non-tender and mobile hard pylorus that is 1 to 2 cm in diameter, described as an olive, may be present in the right upper quadrant at the lateral edge of the rectus abdominis muscle. So, nabubuo na dito ang pyloric stenosis sa kanyang rectus abdominal muscle. So, next is gastric peristalsis. Clinicians may also observe gastric peristalsis just prior to emesis as the peristaltic waves try to overcome the obstruction. So, ma-observe na ng isang healthcare provider ang muscle contractions sa bata and unable na siya mag-ingest ng food through his/her digestive tract.
Assessment and diagnostic findings. First is laboratory studies. Laboratory studies is electrolytes pH, BAN, and creatinine level should be obtained at the same time as intravenous access in patients with pyloric stenosis. Next is ultrasonography. Ultrasonography, if the clinical presentation is typical and an olive is felt, the diagnosis is almost certain. However, formal ultrasonography is still recommended to evaluate the pylorus and confirm the diagnosis. Ultrasonography, ito yung gamit na nakikita ang organs mo at tissues sa katawan. Nakikita ito sa computer screen and may be used to help diagnose and disease such as cancer. Next is radiography. Radiographic studies with barium swallow show an abnormal retention of barium in the stomach and increased peristalsis. Radiography using X-rays, gamma rays to create an image in conventional radiography. X-rays is produced by an X-ray generator and projected towards the object. Medical management. Treatment of a child with pyloric stenosis include pre-hospital care as well as pediatric resuscitations. Pre-hospital care and patient with pyloric stenosis should be consistent with pediatric advance. Life support pulse. Recommendations for infants who are dehydrated or in shocks. Correction of dehydration. If significant dehydration has occurred, immediate treatment requires correction of fluid loss, electrolytes, and acid-base imbalance starting with an initial fluid bolus. 2 ml of isotonic crystalloid. Next, diet. Diet is feeding can be initiated 4 to 8 hours after recovery from anesthesia. Although earlier feeding has been studied, infants who are fed earlier than 4 hours do not have a worse total clinical outcome. However, they do vomit more frequently and more severely, leading to significant discomfort for the patient and anxiety for the parents. Next is phloromyotomy, a surgical procedure called phloromyotomy, also known as the Fred Darmstadt operation, is the treatment of choice. Next is pharmacologic management. Medication used to treat pyloric stenosis symptomatically are IV atropine. The intravenous of atropine for treatment of pyloric stenosis ranges in study from 0.04 to 0.225 mg and kg per day, and is given for 1 to 10 days. Oral atropine. Oral atropine 0.08 up to 0.45 mg is continued after IV therapy has been successful for 3 weeks to 4 months. Nursing management. Nursing management in a child with pyloric stenosis include nursing assessment. Assessment in the child with pyloric stenosis include assess the child history of vomiting, ask when the vomiting started and determine the character of vomiting. Assess the child's elimination. Ask the caregiver about constipation and scanty urine. Ito, tanungin yung caregiver kung about sa constipation ng ihi or urine ng bata. Physical exam. Physical exam reveals an infant who may show signs of dehydration obtained in the infant's weight and observe skin turgor and skin condition anterior nil temperature, apical pulse rate, irritability, lethargy, urine, lips, and mucous membrane of the mouth. And eyes, observe for visible gastric peristalsis when the infant is eating. So ito, i-observe yung infant habang infant habang siya ay kumakain, kung anong kuwan ng kanyang mga mata, mouth at saka lips. So kung anong observation mo sa bata. So that's all. Thank you.